Hello there, welcome to ShineTech's YouTube channel. In this video, we are going to look at focal segmental glomerulosclerosis under the topic, the pathology of the kidney and its collecting system. So in this video series, we are looking at primary glomerular diseases. In my previous video, we looked at minimal change disease, and now we are going to look at focal segmental glomerulosclerosis. So the diseases which affect the kidney nephron are divided into those which affect the glomerulus, the kidney tubules, and those which affect the blood vessels. Okay, so in minimal change disease, we said we had what we call infestment of food processes. That was the main change which took place. Okay, so we have this normal glomeruli, which has the endothelial cells which lines the blood vessel. We also have another layer which is called the glomerular basement membrane, and we had the podocyte which has what we call food processes. Okay, so for a filtrate, for anything to be filtered from the blood vessel into the urine, it has to pass all these three layers. Okay, now in minimal change disease, we observed that the infestment of the food processes caused loss of proteins in the urine, and it was selective. It only involved one type of protein, which is albumin. Okay, now let's look at focal segmental glomerulosclerosis. Now, in this condition, we have what we call sclerosis taking place in one part of the affected glomerulus. Remember here, it's not all the glomeruli of the kidney which are affected. That's why it is called focal. And in that affected glomeruli or glomerulus, only a segment, only a part of that glomeruli is also affected. Okay, so this is a normal glomerulus, okay, where we have blood coming from the afferent arteriole coming to the glomerulus, and the endothelial cells lining in the glomerulus are specialized. They have what we call fenestrations, okay, which filters the wastes into urine, and the filtered molecules passes in the kidney tubules to the collecting duct and finally into the bladder. Okay, so in focal segmental glomerular sclerosis, we only have a segment which is affected. That's why it is called segmental. Okay, and focal segmental glomerulosclerosis can be primary or secondary. Primary, the etiology or the cause is not known, then that is idiopathic. And secondary, that is, it is secondary or it is caused by to another secondary condition, okay, such as HIV infection or heroin abuse, or secondary to other forms of glomerular nephritis, for example AGA, immunoglobulin A nephropathy, or it can be caused as a maladaptation to nephron loss, or as a result of inherited forms. Okay, so those are the secondary. It can be secondary to those conditions. So moving on to the pathogenesis. But before we move on to pathogenesis, glomerular focal segmental glomerulosclerosis, okay, the primary part accounts for approximately 20 to 30% of cases of the nephrotic syndrome. Remember, this is also an example of nephrotic syndrome. Okay, and we said that in nephrotic syndrome we have about three main features which are observed. In nephrotic syndrome, we have proteinuria, which is loss of protein in urine. We have hypoalbuminemia, which is low levels of albumin in the blood, and we also have what we call hyperlipidemia. Okay, when we have loss of protein, we may lose essential proteins which regulate synthesis of lipids by the liver. So when those proteins are lost in the urine, we are going to have what we call higher synthesis of lipids, which is hyperlipidemia. lipidemia. Okay, and some of those lipids may be lost in urine, and that is called lipiduria. Okay, so those are the features of nephrotic syndrome. Okay, so moving on to the pathogenesis of local focal segmental glomerulosclerosis. So this condition is as a result of injury to podocytes. Okay, so the injury is not well known as in minimal change disease, but there are some chemicals which cause this injury to podocytes, and that injury will initiate the event of primary focal segmental glomerulosclerosis. Okay, and the injury, the cause, is not known. So after that, as with minimal change disease, permeability will increase. Okay, will increase. Permeability increasing will increase, and this permeability will be increased due to the factors produced by the lymphocytes. Okay, so these factors are suspected. Okay, so permeability increasing factors which are produced by lymphocytes are suspected in this condition. And due to that injury, we know when we have an injury, a scar can be formed. Okay, we are going to have deposition of hyaline. Hyaline is going to be deposited in the glomeruli, which is going to cause in the glomeruli, and it is caused by the entrapment of plasma proteins and lipids in foci of injury. So we are going to have deposition of proteins and lipids in that foci of the injury. Okay, and deposition of hyaline. So the main result, the main end result is scar. So we're going to have a scar which is going to cause hardening. That's why it is called sclerosis. Okay, which will cause hardening of the glomeruli. So that is all about the pathogenesis. We have an injury, and then we're going to have hyaline deposition in the foci, and we also have protein and lipids deposition there, and the end result is a scar. That is why it is sclerosis. Okay, so the morphology. Now the morphology of FSGS. Okay, so primary FSGS initially affects only the juxtamedullary glomeruli, but eventually all levels of the cortex are affected. Remember, we said only a segment, okay, is affected, but after some time all the glomeruli may be affected, and it can also move on to other glomeruli of the kidney, leading to the end stage renal disease. Okay, so other affected glomeruli will exhibit an increase in mesangial matrix. Okay, so we have mesangial matrix here, we have mesangial matrix there. Okay, so this is where the mesangial cells are, and then we also have the mesangial matrix there. So that mesangial matrix will increase. Okay, so it will increase, and we have obliterated capillary lumina, and we also have deposition of hyaline, as I alluded in the pathogenesis. And the main feature, we also have foamy macrophages, which we have lipid depositions in the macrophage, and then we also have what we call the affected glomeruli. We'll review in what we call the immunofluorescent microscope. It will review trapping of immunoglobulins. Okay, so we are going to observe trapping of immunoglobulins in the glomeruli when we use what we call the immunofluorescent microscope. Remember, immunofluorescent microscope reviewed nothing in minimal change disease, but here it is going to show trapping of immunoglobulins. Okay, and usually these immunoglobulins are IgM, and we also have complement in the area of hyalinosis, where we have deposition of hyaline we are going to observe deposition, trapping of complement proteins and IgM immunoglobulins. Okay, so if we use an electron microscope, we are going to observe effacement of food processes, as in minimal change disease. We are going to observe effacement of food processes. Okay, wearing off of the food processes of of podocytes is going to be observed. Then with time, that the same disease can progress to global sclerosis of the glomeruli. So if we have global sclerosis of the glomeruli, from the segment it can involve the whole glomeruli. Okay, and we also have pronounced tubular atrophy. So this is caused by laden, okay, trapping of proteins on the layers of the tubules. So that will cause the tubules to stop functioning. Nutrition also will be suspended. So remember, we have a lumen here with these cells. Then now we have a layer of proteins which are being trapped here, a laden layer of lipids and protein. These are the tubular cells, and now in the tubule there we have a laden of proteins. So due to that laden of proteins, oxygen and other nutrients won't be absorbed by the tubular cells. That will result into atrophy of those tubular cells, and we are going to have interstitial fibrosis also is going to be observed. But now in other conditions, secondary conditions such as HIV infection, drug-induced toxicities, we also observe what we call collapsing of glomerulus, which is called collapsing glomerulopathy. Okay, so that is also going to be observed. So moving on to clinical features, it is important here to distinguish focal segmental glomerulosclerosis from minimal change, because the clinical cause and responses to therapy are different. Okay, here in FSGS we have poor response to corticosteroids, but in minimal change there is a good response to corticosteroids. And on clinical features of FSGS we have hematuria, so this can differentiate it from minimal change disease. And we also have hypertension, so these two are not observed in minimal change disease. We also have non-selective proteinuria, so the proteins which are lost is not albumin only, but we also have other proteins. That's why it is called non-selective. And this can in 50% of patients with this condition would develop end-stage renal disease, okay, within 10 years of diagnosis. So within an estimate of 10 years, the result, okay, of focal segmental glomerulosclerosis will be end-stage renal disease, where we are going to have renal failure. Okay, so as a summary on clinical features, we are going to observe hematuria, hypertension, non-selective proteinuria, and in 50% they will develop end-stage renal disease in an estimate of 10 years, and we have poor response to corticosteroids. Okay, so thank you so much for watching. Don't forget to like, subscribe, and leave your comment in the comment section below.